2022. I am Dr. Alok and I am in discussion with one of the foremost physicians of the country, Dr. Sudhir Bhandari, and he is the pioneer in management of COVID cases in India. We'll have a discussion. Dr. Bhandari, welcome to NUCD.
Thank you.
You remember when the first wave came, you are the one of the first few physicians or doctors who handled it courageously. When we did not know anything about the virus, nothing about the disease, nor even about the drugs. What was the initial challenges for you?
It's a very interesting question. I must share with you, sir, that when the first wave came, our fear psychosis was peak and our confidence was very low because we did not know how to handle it. But we very patiently, very judiciously and with academic manner we handled it because, when the first 3 Italian patients came to Jaipur with the COVID positivity, we did not have a specific drug to be used. So we very prudently and very interestingly, we did the research and we wanted to create a bridge between point of no treatment till the specific treatment will be available. And after thorough review of literature, we created a bridge of using 2 antiviral drugs, that is lopinavir and ritonavir and 1 hydroxychloroquine, and we got the ratification of the ICMR. Now, you'll be extremely happy to know, sir, that all our 3 Italian patients became negative with ritonavir, lopinavir combination with hydroxychloroquine. We got queries all over the world. We got queries from United Nations. We got queries from White House. Now, going back to that time, you'll be extremely happy to know, as of today, the first effective drug for Omicron is Pfizer's Paxlovid. You must have heard the newly introduced Paxlovid these days in America. And this Paxlovid is a combination of 2 antiviral drugs. One is the new antiviral drug known as nirmatrelvir, and second is a ritonavir, which we used in March 2020. So we created a combination of drugs and we used antiviral drugs. We created the infrastructure and we intensely worked on the investigation. We were the pioneer institute to do the 200 to 300 CT scans per day, including pulmonary angiography, to find out the microvascular complications of the COVID. So we handled it by new combination of drug, intense investigation, which included D-dimer, IL-6. We started working on the cytokine storm, CT angio, pulmonary CT angio for pulmonary thromboembolization, and all kind of respiratory support. After that came the remdesivir. At one stage, WHO did not agree with remdesivir, but we spoke a lot in favor of remdesivir, and immediately that we heard that US FDA approved the remdesivir. We picked up the early diagnosis of cytokine storm and we started using a drug tocilizumab as early as in March 20, and which was ratified by UK in November 20. So we were very brisk to make use of situation. Meanwhile, we created the infrastructure, more ICU beds, more oxygenated thing. Sir, I would share with you the clinical difference in the first wave when the COVID was having R naught, that is 1 person will infect how many other person with a value of 2. In the second wave, which came Delta wave in April 21, which has a very excessive R naught, that is 7 to 8. So this one patient of Delta infected 7 to 8 patients, and which is almost 3 times in present Omicron, which is 20 to 25. So initially, our confidence was low, but we found out antiviral drugs, supportive treatment, management of cytokine storm, and created the infrastructure. We gave hydroxychloroquine prophylaxis to all the health workers, and they stood prevented. So this is the way we developed the confidence in second wave. We developed immense infrastructure. Second wave, as you know, was a very aggressive wave. It caused lot of mortality and morbidity that required early oxygenation and ventilation. In first wave, 10 to 12% people required hospitalization, but not so critical. In second wave, 10 to 20% required hospitalization, and they had a high morbidity and mortality. A lot of them went on high flow oxygenation, BiPAP machine, non-ventilation, and then intubated ventilation. The cytokine storm was huge. The post-COVID hyperglycemia was a major issue. Patient developed huge complication in terms of mucormycosis or black fungus. These were the challenges of second wave.
Yes.
But sir, yeah. So this is the way we develop the infrastructure and treatment methodologies.
Dr. Bhandari, it's so interesting to know about your journey and so advanced in your approach. But in the second wave, we found that the diabetes was causing a bigger problem. There were new onset diabetics, steroid-induced diabetics, and managing glucose was really, cytokine storm was taking hayward and we had problem. What was your experience in handling diabetics?
Sir, let me first explain to you our experience of second wave. Suddenly, second wave started in month of April and May. By the time people had received only single dose vaccination. That too also 30 to 40% only senior citizens. So population was not very well protected. So in second wave, we started having huge respiratory embarrassment, early hypoxemia, patient requiring early oxygenation, and there was a paucity of the ICU and the oxygenated bed. Now the reason was huge and high incidence of pulmonary pneumonia, and people used to have infiltrates in the lung with a very high scoring. Secondly, we started having issues of ARDS. Thirdly, very high pulmonary embolization with raised D dimer. This was coupled up with the cytokine storm, which was diagnosed by high IL-6, high CRP, high ferritin, high LDH. These were the important markers which most of the people had. So we had to manage the viral phase, the first week, in which we used the antiviral drugs. The remdesivir was a mainstay. In the second week, we had to manage the cytokine storm, which we managed with the drugs like tocilizumab and the steroids as per the recovery trial. And many times we use the COVID plasma to begin with. But what happens? This was coupled up with significant hyperglycemia. There was a new onset diabetes. There was a people turning diabetes who were glucose intolerant. People having uncontrolled diabetes who were having controlled diabetes. This was partly because of remdesivir, partly because of delta variant itself was found to affect the beta cell, and there was a hypoinsulinemia. And thirdly, the steroid was the mainstay of treatment as per recovery trial, which also led to the hyperglycemia. So uncontrolled hyperglycemia was one of the challenges in the second wave, along with the respiratory and the pulmonary components. But we managed this hyperglycemia by DPP-4 inhibitors, which was absolutely recommended in case of, but mainly was the insulinization. As per the needs and demands, we use the basal bolus, we use the twice a day, we use the basal insulin, those who are marginal patients, but definitely almost 70% patient required management of hyperglycemia. Now, this hyperglycemia invited a new trouble in the second wave, that a big number of patients develop black fungus or mucormycosis. And etiopathogenesis to the black fungus or mucormycosis were attributed to A, delta virus itself, B, because of massive thromboembolic phenomena, there was a tissue necrosis where the fungus grows. So we had a lot of issues of the oral black fungus, the loss of vision, the central nervous system black fungus, and at the same time, the hyperglycemia as a result of virus, as a result of remdesivir, and as a result of steroids as per the recovery trial. So we had to be very careful about this thing. Most of the patient requires oxygenation. So we used to use the wetting water in the oxygen concentrator, the oxygen supply. So that also was a risk for the fungal infection. So truly speaking, we had to manage, number one, the most important aggressive pulmonary insufficiency by oxygenation and various modes of ventilation. Secondly, we had to manage associated septicemia or multi-organ failure as a result of cytokine storm. Thirdly, we had to manage in each and every patient the uncontrolled hyperglycemia flare-up or new onset diabetes, and in some patients who develop the black fungus or mucormycosis. So second wave was very challenging, and above all, many patients who recovered, they suffered post-COVID complication or post-COVID syndrome, which was significant in second wave than first wave. Especially the post-COVID pulmonary fibrosis was the biggest challenge. Post-COVID fungal infection in the form of aspergillosis, it was another big challenge we had. So a lot of post-COVID syndrome, and post-COVID, we have a saying in medicine, from head to toe, whether CNS, the forgetfulness, the clouding of concentration, the visual disturbances, persistent headache, the loss of appetite, loss of taste, depressive symptoms, psychosocial symptom was another big challenge, because each and every family lost someone their member or someone their friend or acquaintances. So tremendous psychosocial trauma was also a very important outcome of second wave. But by the time the vaccination began, so we have been very lucky. Our country produced indigenous vaccines. Look at today, we have vaccinated more than 153 crore people, more than summation of populations of many countries. So probably a wonderful vaccination drive which crossed across the second wave, and now 93% people have got first dose in our country, 70% plus has got 7 doses in country, and which is protecting us from any more side effect. And that's the reason the way we migrated from aggressive second wave to third wave, probably vaccination is protecting us in severe, critical, and ventilatory required state of the COVID.
Dr. Bhandari, that's very nice. But now third wave has come, and Omicron is spreading very rapidly. And what is your forecast? How do our hospitals will be burdened? Will it have that much of ICU load, or what do you think?
Sir, it's a very intelligent question. Probably you are well aware of everything, sir. That hospitalization in the second was to the tune of 20% because of respiratory insufficiency and complications. The hospitalization in the Omicron is less than 1% or 0.5%. As I said to you, sir, that R naught value of Omicron is 20 to 25 against 7 to 8 of Delta wave. It means one infected person, if not taken care of, not use the mask and the social distancing, can infect 25%. But few reasons. A, we are well vaccinated. B, our herd immunity is very good. I'll give an example. In the state of Rajasthan, we did a sero surveillance, and you'll be surprised. We found herd immunity or significant antibodies up to 91%. Sir, when this sero surveillance was done, the children vaccination had not started, and by that time, 74% children had protective antibodies. It means there was a subclinical infection. So a good vaccination, good herd immunity by subclinical infection has been protecting us against significant, moderate, and critical Omicron symptoms. So far, 98% Omicron people are asymptomatic or mildly symptomatic. There has been another theory, sir, that though there has been a 30 type of mutations on the spikes of the Omicron, but because of TMPRSS receptor, which is affected in essential for penetration of these spike proteins into the lung, which is not happening. So these Omicron viruses are not able to penetrate lung. People are devoid of pulmonary pneumonia, except people with the elderly age, comorbid condition. That's a part apart, immunocompromised people. Otherwise, because of TMPRSS receptor not coming into action, like they are not able to penetrate the lungs, and there's only superficial symptoms of ILI like coryza, sore throat, mild fever, etc. Another important thing is that, so your question, practically there's a less than 0.5% people requiring hospitalization. ICU beds are empty, unlike second wave. Wards, oxygenated beds are empty, unlike second wave. And all those few patients who are in ICU requiring oxygen and ventilation are the unvaccinated ones, sir. Very strong statement it is that 80% of the admitted patients are unvaccinated, or they are the people who got vaccination before the June of 20. It means the antibody levels have fallen down within 3 to 6 months. And that's the reason there's a logic of prefixing or pre-transferring to the booster dose to a lesser duration. And even we may think of the second booster dose like many countries have thought of it. So as on today, Omicron is not causing any burden on the health system. But another important thing, sir, you can deal with pandemic in two ways. To treat, you, me, all can jointly treat, infrastructure can do. But that is not a way. A more important thing is to prevent. Sir, thousands and lakhs of the patient, like 14 lakh patients today in America, if it comes to India, our hospitals will be short of the place and the manpower. The issue is that prevention can happen only by vaccination or masking and social distancing. Sir, masking is extremely important in Omicron because of R0 factor is 20 to 25. One affected person of Omicron can affect 20 to 25. Secondly, the risk of affecting other is so high, sir, because most of these people are asymptomatic or mildly symptomatic. So patient may take it as a casual mild cold or casual coryza, not take seriously that it could be Omicron. He may not use mask, he may not maintain social distancing, and he can infect others. So because of the milder nature of the symptomatology of Omicron, probably the masking is much more important. And you know it very well, sir, that an infected person wears the mask. Practically, he protects 95% the people around. Absolutely. But even if we are wearing mask and there's an infected person unmasked, our exposure chances are very high. Sir. So I think as on today, there's no burden on health system, provided people at large cooperate with us to maintain this no burden state.
Thank you. Thank you so much, Dr. Bhandari. It was nice talking to you. And when listening from the most expert of the country, it gives a lot of a positive sense.
Sir, I would like to say a few words about the treatment part of Omicron, sir.
Yes, please.
People should know. Now, we need to know the treatment methodologies. The best drug for Omicron is a Paxlovid. And Paxlovid is one drug which is available, is by Pfizer. The combination of nirmatrelvir with ritonavir. Second best drug is Stromivab, which is a newer monoclonal antibody. Third is a remdesivir can be used, but for 3 doses only, 200 on day 1, then 100 on day 2 and day 3. And lastly is tolpuviramab. There's been some controversy about that, so we'll not talk about it. So this is the way we can handle. Otherwise, in a significant or moderate cases, otherwise simple medications are enough to treat the asymptomatic or mild patients.
Very nice. I think our delegates must have understood a lot of it. They must have gathered a lot of things. Thank you very much, Dr. Bhandari, and we'll meet you in the panel discussion. Thank you so much.
Thank you.
Thank you so much.